Thank you for having me come on. Really, one of the most important things that we can do for our community is to transmit accurate information. And this is my opportunity to help make sure that the information that's going out to the community is accurate as far as the health and the science. I'll do my usual update with a couple of important pieces of news at the end. So there are currently over 3.3 million people infected with COVID-19 and over 222,000 deaths worldwide. In the US, we have nearly 1.1 million infections as of today and almost 63,000 deaths, accounting for a third of all infections and 28% of the deaths worldwide. There's still, consistently over 20,000 new cases and 2,000 deaths in the US daily. And just to put that in perspective, that's basically a 9/11 event every 3 days in terms of the number of deaths. So even though we're there's some optimism here, we need to understand that the situation is still pretty dire. One way to look at these numbers is that worldwide, if you look at the numbers I just gave you, about 6% of the people infected have died, and in the US it's about 5%. For comparison, the 1918 flu pandemic, and I'm staying away from the word Spanish flu because I do believe that locating it in a particular place is stigmatizing. The 1918 flu pandemic had a death rate of over 2.5%, or about half of the COVID pandemic. Now the 1918 pandemic killed 50 million people and over 600,000 Americans. And so based on these numbers, the original estimates of what COVID-19 would have done absent a proper response, where we would expect about 1 to 2 million deaths in the United States, fits the data. And so I do want us to encourage us to think that even though it's terrible that 63,000 Americans have died, can you imagine the grief and suffering if there were 10 to 20 times more deaths? And we have to credit both the public health policy response and our healthcare workers for this outcome. One new focus on the hotspots, food processing plants, which we know often employ racial and ethnic minorities, are the new infection hotspots. There are outbreaks in 80 plants in 26 states, 4,400 infections or more, and 18 deaths. Over 25% of the plants have shut down. And in response, President Trump has issued an executive order to force them to stay open. But it's not clear that any additional safety measures will be mandated or supported by the government to protect the workers. And we could imagine that if they're forced to stay open with the same rates of infection, that minority workers are going to suffer disproportionately. The good news since the last briefing is that there is evidence that the pandemic is slowing down in the United States. I would call it bad news that some Americans, including some leaders, are beginning to push back against the public health policies that have led to these lower numbers. Many states are planning on reopening in the next week or two, but there's a lot of confusion over statewide versus local orders. CNN did put together a nice page that lists what each state is doing, and I can send it out in the chat box after I'm done talking. Remember that one condition for reopening is that we need a sustained period of time, possibly from 7 to 14 days, when the new number of cases are not rising. So I reviewed the new number of cases in each state, and what I found was that none of the states with the highest number of cases have even had 3 straight days without a rise in the number of new cases. And that includes New York, New Jersey, Massachusetts, Illinois, California, Pennsylvania, Florida, Michigan, and Texas. In Georgia, where the governor has been very aggressive in approaching reopening, the new number of cases in the last 5 days, I'll just read them out to you: 1,075, 264, 816, 579, 718, 802. You really can't look at that pattern and say that we've flattened out already. So it's clear that the decision to reopen are being made, just as the decision to go into shelter in place is based on more than just public health considerations. NIAID Director Fauci has already warned that reopening too soon may trigger a second wave of infections, and I am myself very concerned. On the treatment front, there is one retrospective study that is not randomized or controlled, so not a great quality study, showing that hydroxychloroquine did not help in COVID infection and was actually associated with a higher death rate. So again, I think I said it the last time, but This basically means that we should not be giving hydroxychloroquine except in a research study, as there is clear evidence of harm and no evidence of benefit to date so far. The big news this week on the treatment side is remdesivir, which has some mixed data, but overall, I think the findings are very good. The journal Lancet published a Chinese randomized control study that showed no effect of the drug versus placebo. But the study only enrolled half of the patients they were planned to enroll because the pandemic has slowed down in China by the time they started the study. So the two interpretation of finding that the drug didn't do any better than placebo is either the drug did not work or that the effect was not picked up, even if it did work, because the study sample size was too small, or what we in research call it was underpowered. The big study, which has not been published, so we can't really review very carefully, is what we call an interim analysis, which is not a final analysis, but just looking at a bunch of patients who've been enrolled of a randomized control study in the United States done by the National Institutes of Health. And what it found was that the time to recovery on the drug remdesivir was faster by 3 days compared to placebo. And the mortality improvement was 8% of the people on remdesivir die versus 11% of the placebo group. So that's a difference of 3%, which is pretty big. But the finding was statistically borderline significant. For those of you who are interested in that, the p-value that we use is 0.05. This particular one is 0.059. So we couldn't say that exactly for sure that it did actually improve mortality. But because it was an interim analysis, I think the final analysis will confirm the mortality benefit. And then a third randomized study from China showed that 5 days of treatment is the same as 10 days of treatment with remdesivir. So the summary of these findings is that we now have a drug that has clinical benefits. By reducing the time to recovery, that will reduce the burden on the healthcare system in terms of ICU beds and hospital beds. Remdesivir may also save lives, as I described. And we don't need a long course of treatment. 5 days is fine. This is very important because to produce a drug in a big enough quantity for a pandemic. And so they have the company that makes it has to ramp up production. They don't have enough doses right now probably for everyone who needs it. Together with slowing down the number of cases due to the public health response, the drug is helping us see the light at the end of the tunnel. And that's the end of my presentation. Thank you.